Good morning, good afternoon, and good evening. Thank you for joining us today for a discussion on maternal mental health, providing care and support in the perinatal period, hosted by the Wilson Center's Maternal Health Initiative and UNFPA. I'm Sarah Barnes, and I direct the Maternal Health Initiative, or MHI, at the Woodrow Wilson International Center for Scholars, and I will be your moderator for today. For those of you who are not familiar, the Wilson Center is a DC-based think tank that brings fresh thinking and deep expertise to the most pressing policy challenges we face today. We work to create a global dialogue of ideas that Congress, the administration, and the international policy and health community can act on. Today, we're speaking about mental health, and particularly during the perinatal period. And this is the period including pregnancy and the year postpartum. Sunday was World Mental Health Day, and this month is Pregnancy and Infant Loss Awareness Month. In recognition of these dates, in addition to today's event, MHI has recently launched a policy brief on perinatal mental health in the United States and a 3-article series published on the .mom column dedicated to these issues. The series is written by Adrienne Griffin, who's the executive director of the Maternal Mental Health Leadership Alliance. In addition, since announcing this event, several organizations have reached out to us to share their work and long-standing expertise in perinatal mental health. And we invite any of you who are watching who work in this space to reach out to us and share your work and experience. We are always happy to collaborate and help amplify your work. You can email us at mhi@wilsoncenter.org. We're always keen to learn from our peers, so we thank you in advance. So a recent Lancet study found that the pandemic is responsible for an additional 53 million cases of major depressive disorder and 76 million cases of anxiety disorder across some 200 countries, with women and young people most affected. The compounded stress for pregnant people during the pandemic cannot be overstated. Even prior to the pandemic, studies show an estimated 15 to 20% of women will experience a perinatal mental health condition. Moreover, women are more likely to develop anxiety or depression in the year after giving birth than in any other time in their lives. And suicide and overdose are the leading causes of death in the first year postpartum. And yet, the prevention, early recognition, and treatment of perinatal mental health conditions is a challenge for many, if not most, healthcare systems across the world. Sadly, an estimated 75% of women with a perinatal mental health condition will not get the help that they need. We know that perinatal mental health care is still not well incorporated into the training of nurses, midwives, and other maternity care providers, and therefore healthcare providers who have contact with women and their families, often across the entire life course, do not always have the knowledge and skills to adequately support the perinatal health needs of women and birthing people. Fortunately, much is being done to help address these issues through improved training and support for healthcare workers, and we will get to a lot of that in our discussion today. One example is UNFPA Asia and Pacific Regional Office, together with UNFPA headquarters and Burnett Institute in Australia, has developed and implemented perinatal mental health capacity building training, which has already been very well received by midwives and other healthcare providers in Papua New Guinea, Bangladesh, Myanmar, Afghanistan, and Laos. Also, UNFPA and others are currently developing new resources and research to support midwifery educators to train midwives in perinatal mental health. And they're looking at training packages to strengthen the skills of midwives in this space, and also find ways to address the very real mental health issues of midwives and healthcare providers themselves, resulting from the stress of dealing with their work and their overwork and the maternal and newborn deaths and disabilities they witness through their daily work. And then, of course, we have all the work and successes of our panelists today, who we are about to hear from. I am honored to be virtually sitting here with this incredible group of speakers who will help us tackle these topics through their expertise and lived experiences and move us toward solutions. I would like to wholeheartedly thank all of the speakers today for your commitment to these issues and for joining us in this discussion. I would also like to thank my team at the Wilson Center, particularly Dikshita Ramanarayanan and our AV team, as well as my colleagues at UNFPA, Geeta Lal and Sarah Barzi. So now before we start, just a bit of housekeeping. We're doing things a little bit differently today. So first we'll have 3 presentations, one to set the stage and cover the landscape of maternal mental health, and then 2 on specific maternal mental health projects, one in Zimbabwe and one in the United States. Then we'll bring in 2 discussants to share responses to the presentations, as well as insights into their own work. And then finally, we'll come back together, all of us, for a group Q&A session. So I'd like to thank everyone who's tuning in today, as well as everyone who sent in questions ahead of time. We will do our best to incorporate all of those questions into our discussion. And you can please feel free to follow along today on Twitter. We're at Wilson_MHI, and you can use the hashtags PMH Matters and MH Dialogue. Also, a recording will be made available after today's event, and PowerPoint presentations will be shared on our website. So without further ado, let's get started. Today, we're going to start with Nirja Chahardi, who is a technical officer in the Department of Mental Health and Substance Use at the World Health Organization, or WHO. She is a psychiatrist by training, and she works in the brain health team and is the focal point for maternal mental health. WHO is currently developing much needed capacity building training materials in the area of maternal mental health, and Nirja is going to kick things off with an overview of mental health and maternal mental health globally. Welcome, Nirja, the floor is yours.
Thanks a lot, Sarah. And hello, everyone, and thank you for your interest in this really important topic. And I'm so happy to be able to speak to you about it. So as Sarah said, I'll begin with some facts about mental health. I think you need to change your screen, Dikshita, your slides. Maybe you need to swap screen right on top. Okay, let me continue. Just to go over some of the numbers that Sarah also mentioned to you when we come to mental health. The next slide, please, Dikshita, thank you. So close to 1 billion people, that is, we're talking about 13% of the world's population, are deemed to have a mental disorder. Now, these numbers are really quite large. Of particular concern to us is that most mental health conditions begin in adolescence. And in fact, these numbers are rising, with 14% of the world's adolescents suffering from a mental disorder. Apart from causing a lot of personal distress and costs to people affected, their families and communities, the societal costs of anxiety and depression are daunting, as you can see here. We've already heard Sarah describe to you the effects of the pandemic and the toll that they're taking on mental health for many of us, including for women and pregnant women and women in the perinatal period. There are devastating impacts of social isolation and socioeconomic pressures, and this all just speaks to us of the great need to scale up mental health services worldwide. This need is further emphasized by the high mortality that is attributable to suicide, not least of all in young people, and also the mortality that is attributable to alcohol and drug use, for example. Despite the enormous burden of these conditions, as you heard Sarah describe, mental health is still one of the most neglected areas of public health. And in fact, though we have effective treatments, and we know that these treatments are also cost effective, almost 75% of people in low and middle income countries do not receive any care for their treatment. And amongst those who do, a very few proportion receive evidence-based quality care. Well, I think we can move on to the next slide. Thank you. So now moving on to maternal mental health. And The next slide takes us to what we consider as the what do we include under this umbrella of maternal mental health. So we are talking about a woman's mental health during pregnancy and the postpartum period. And this encompasses the full spectrum of mental health problems that can affect a woman during pregnancy or up to 1 year postnatally. Amongst these conditions, depression and anxiety are the most common conditions, but also there are important conditions that can cause a lot of disability and distress, such as psychosis, bipolar disorder, and alcohol and drug use disorder. We also need to remember that it's not only mothers, but also fathers and other primary caregivers who can experience stress and anxiety during the perinatal period, and this also needs our attention. In low and middle income countries, 1 in 5 women will have perinatal depression. And in addition, about 20% of women with perinatal mental health conditions experience suicidal thoughts or undertake acts of self-harm. COVID-19, as you heard Sarah mention, has also exacted its toll on this population with increased prevalence of depression and anxiety. The next slide. So what is the impact of perinatal mental health conditions on the woman? You'll see here many quotes from women who have either depression or anxiety in the perinatal period. They experience guilt, they experience, they describe feeling ashamed and worthless, say that this is akin to a living hell, and that they also feel extremely isolated and are unable to share their feelings with others. There are health impacts, not least of all because of decrease in help seeking, because during the antenatal and postnatal period, there are poor obstetric outcomes. There's also unhealthy choices such as tobacco consumption, harmful use of alcohol and drugs. And we already heard about the unacceptably high suicide rates. The depression and anxiety in women also affects the mother-child relationship. The important thing is that these impacts are intergenerational. So the consequences of untreated maternal depression and anxiety is beyond just increasing the morbidity and mortality in the mother, but is also associated with an increase in a range of cognitive, psychological, and developmental disturbances in children. For example, children of mothers with depression are up to 1.5 times more likely to be either underweight or stunted. The next slide. The good news is that we can do something about this, and let's not lose the various opportunities that lie ahead of us. Just to describe a few in the next slide. There are other initiatives you'll be hearing about in the rest of the meeting, but let me just describe to you what WHO has and is doing in this space. WHO's MHGAP program, which began in fact 2008, is based on the WHO evidence-based guidelines. These guidelines have a suite of technical products associated with it, such as the intervention guide. And the intervention guide basically has simple algorithms that can be used to train non-specialists to assess and manage a range of mental health conditions, including depression and anxiety, and can be used to train healthcare providers working in maternal and child health services. They come with training manuals and also an app. Then there is also the WHO Thinking Healthy Manual, which is an evidence-based cognitive behavior therapy-based manual for, again, healthcare providers to be able to provide psychosocial treatments for mothers with anxiety and depression. This has been already used in many parts of the world. Is found to be effective and cost-effective and can upskill the community health workers with the tools that they need to help improve the women's mental health and also their relationship with the infant as well as the family. Speaking about WHO guidelines, there is the recently released guideline on improving early child development. And these guidelines have recommendations specifically for integrating psychosocial interventions to support maternal mental health into early child health and development programs. And this is so, so intuitive because this is where women are seen. This is where they can be recognized and screened to recognize the mental health conditions and then to provide care for them. WHO is updating its postnatal care guidelines. And in fact, these guidelines are going to be released early next year. And there are going to be recommendations for screening as well as for prevention of depression and anxiety in the postnatal period. We are also developing and field testing an implementation guide, which will help program managers and to support them in integrating maternal mental health into their programs, whether these are maternal and child health programs or primary healthcare programs, or even programs for early child development. The next slide. So just some key messages before I hand back to Sarah. One is that there are evidence-based interventions for prevention and treatment of common perinatal mental health conditions. These interventions are effective and cost-effective. They're not expensive. They can be provided as a part of routine maternal and child health care by trained non-specialist health workers. They can be delivered in a stepped care manner, which means that basic psychosocial care and support can be delivered to all women in the perinatal period, while women who might be at risk for depression and anxiety or who have these conditions can be provided more resource-intensive treatments and perhaps referral to specialists if needed. Let me end here and thank you very much for listening, and back to you, Sarah.
Thank you so much, Nirja. That was a really great overview. And you kind of already touched on this, and I wanted to just ask you a quick follow-up just for a bit of clarity. So you spoke about both men, women, and children in the presentation within healthcare and public health. And I'm wondering, you talked about a couple different spaces for intervention. Where do you think providers, like when do you think providers should start talking to people about mental health? You know, when's that first opportunity in your thoughts?
Great question, Sarah. And I think that would depend upon which services we're talking about. If we're talking about, for example, maternal and child health services, which begin with antenatal care visits. So the first antenatal care visit is the time to begin speaking about this. And it doesn't end with the first visit. We know that these conditions can occur at any time during antenatal and postnatal period. So it's important to use every opportunity, every contact with the healthcare provider to at least ask a few questions to get a sense whether any more probing or screening is required, and do this at frequent intervals throughout the different contacts.
Okay, great. Thank you very much. We'll come back to you later for more questions. For now, we're going to move to Tafadzwa Meki. Tafadzwa is the founder of SALT Africa, which stands for Someone Always Listens to You. She is a mental health advocate and counseling psychologist in training. She's also an anchor for a weekly show called Mental Health Watch, addressing mental health in Zimbabwean communities. Tafadzwa, the floor is yours. I think you're muted. There you go.
Thank you very much, and thank you for having me here. My discussion will really be about the story of SALT Africa and the case of maternal mental health in Zimbabwe, or the absence, as we will see as we go on through the presentation. We can go on to the next slide. SALT Africa is an initiative which is aimed at combining efforts, existing efforts, the Western efforts which are more palatably used throughout, globally, and adopting Afrocentric mental health solutions to Afrocentric mental health related issues. This having been promulgated by the realization that as Africans, we do not have mental health seeking behavior let alone maternal mental health seeking behavior. And through a needs assessment that we carried out in the rural Zimbabwe, in one of the provinces, we then discovered that there is need to have smart mental health focused solutions which are more acceptable and culturally fitting for Zimbabweans and throughout Africa, and hopefully they will be adopted globally. And with this came the maternal mental health model, which we call Mbuya Nyamukuta. And Mbuya Nyamukuta, Mbuya is a grandmother. Nyamukuta is a term used, a local term used to stand in for midwife. And this will address pre and postnatal maternal mental health issues within rural communities, cascading through to the urban areas, because generally we do not have health-seeking behavior, maternal health-seeking behavior within the rural communities. So this Mbuya Nyamukuta acts as a lay maternal mental health community midwife. We can move forward. If we look at the model's theory of change, we have the Mbuya Nyamukuta being the focal person with regards to maternal mental health delivery. And she addresses issues to do with primary maternal mental health community aids. Increased maternal mental health awareness is one of the deliverables that we'll get out of it. Reduced maternal deaths, reduction of neonatal and infant mortality, stillbirth and pregnancy loss. As I've already alluded to, a lot of the pregnant women, not only in rural Zimbabwe, but throughout Zimbabwe, due to a lot of reasons, financial being one of the main ones, do not have maternal health seeking behavior. We can go forward. Now we look at an overview of maternal mental health in Zimbabwe, and I have deliberately said maternal mental health, but as we proceed, you shall understand why. And according to the World Health Organization global data, Zimbabwe ranks 4th in the world in terms of rates of preterm births and 16.6% preterm births per 100 live births. And about 4,000 neonates die every year, mainly from preventable causes. And these preventable causes, we ask, which ones are they? The rate of decline of these indicators leaves the country off track to meet any of the targets as we look at the SDGs by 2030. High coverages of standard maternal health packages such as antenatal care, skilled birth attendance, postnatal check within 2 days are indicators that care is improving. But though, to what extent and to whose benefit is it improving? However, the stagnating mortality rates imply that there is still much work to be done in terms of provision of quality maternal and child services. We can proceed. The UNICEF Health Program supports the government with interventions, which include mentorship to improve emergency obstetric and newborn care, the development and adaptation of key guidelines and job aids of antenatal care, for instance, for newborn care in all babies, promoting routine maternal and perinatal surveillance, reporting the underlying cause of preventable deaths, and informing policy and corrective measures to put in place to improve future service provision. Again, as much as this is a presentation, the question still stands that as we are saying this data has been collected, but this is being collected in a formal setting, yet we do know and understand that a lot of these women never make it to a local clinic, let alone district hospital. A UNICEF health program technically supports the Ministry of Health in Zimbabwe in sustainably establishing network of community health volunteers. Again, as Sarah and Nerja have alluded to, that a lot is being done with regards to maternal health care. But as we proceed to the next slide, I have this question to pose. Where is maternal mental health? In the previous 2 slides, we have seen the gains of the collaborative efforts being done by World Health Organization and UNICEF and the Ministry of Health and Childcare locally in Zimbabwe, and hopefully throughout many of their success stories. But the question still remains that a lot of these preventable causes that we mentioned can be prevented if we include the maternal mental health aspect as we carry out maternal work throughout not just only Zimbabwe, not just only Africa, but globally, and looking at middle income countries. We can proceed. Maternal mental health, the unseen battle. We may try to curb a lot of causes and reduce deaths and celebrate that we are seeing succeeding gains in mortality decrease. But this can be prevented, and even more deaths can be prevented if we incorporate mental health within our maternal work. Community support groups and male inclusion to promote maternal mental health. We personally believe that we cannot formulate programs for the women and leave out the men. We're equipping women with wisdom, but they're going back to the same men that are still in an empty shell and do not know how to treat the pregnant woman, even to do not know the first and last thing about pre and postnatal care. Increased number of young mothers registering with local clinics and health facilities, which will exceedingly reduce death ultimately, and reduction in maternal deaths in rural communities. Not just rural communities, but this will be cascaded into urban areas and hopefully adopted by other countries and globally. We can proceed. The time to act is now. If we are serious about maternal health, if we are serious about maternal mental health, let's leave this workshop, let's leave this consultative meeting and start to act. Funding is key. There are so many people doing good work out there, but if we really are aiming at achieving SDG 3, which is good health and well-being for all, I think this year's Mental Health Day theme says it. Mental health in an unequal world, unequal in terms of funding, unequal in terms of prioritizing, and. I pose this question to the powers that be, that the time to act is now. I thank you.
Thank you, Tafadzwa, and thank you for that call of action as well. I have a lot of questions for you that we'll get to kind of later at the end, but I wanted to ask you if you could speak a little bit about what led you to found SALT in the first place. What made you feel that it was needed?
I think if you look at how simple the name of the organization is, someone always listens to you. We're looking at a world where mental health, thanks to COVID, I think these are one of the few gains that came from COVID. We are now seeing mental health becoming topical. But prior to that, it was looking at my personal experiences, my personal maternal experiences, what I had to go through, what my partner and I had to go through, what the community was like, what they knew and what they do not know to date, how much easier a journey it could have been for me if I was able to speak out openly about it without judgment and having people pointing fingers at me, how much I could help other women out there to speak up confidently about fertility issues, about maternal issues, about child loss, about failed pregnancies, without being judged and without feeling guilty. So it's mainly anchored, I believe mental health is mainly anchored on talk therapy. The moment you speak, as they say, a problem shared is a problem half solved, regardless of the level of professionalism of that person. It takes a burden off the person going through something. So I think in a nutshell, that's what pushed me to found SALT Africa.
Thank you very much. And I'm sure many, many people are very thankful that you did. I look forward to chatting with you more in a little bit. For now, we're going to move to Kay Matthews. Kay is based in Houston, Texas, and is the founder of the Shades of Blue Project. The Shades of Blue Project is dedicated to helping women of color before, during, and after childbirth with community resources, mental health advocacy, treatment, and support. Kay, the floor is yours.
Thank you so much, and I appreciate the presentations that I've seen thus far. And so my title today is Knowledge Builds Connections and Community Trust. A little bit about us at the Shades of Blue Project. We are dedicated to helping women of color before, during, and after childbirth with community resources, mental health advocacy, treatment, and support. Our mission is to change the way women of color are currently being diagnosed and treated after giving birth and experiencing any adverse maternal mental health outcome. Our vision is that the acknowledge, respect, and support method, we will be the adaptable change agent for the healthcare professionals and the healthcare systems, operations, and engagement with patients. I am a solution-driven person. Here in the US, our maternal mental health rates by numbers. I always say maternal mental health by numbers in comparison by populations don't add up. 1 in 7 white women will experience postpartum depression, yet 1 in 4 women of color will experience it, but go undiagnosed or even acknowledged. That is what we are working towards changing. Again, statistics are great, but what are our solutions? And what Nirja talked about in the beginning is there are community solutions. There are solutions out there, right? You just may not know about them, but they exist. And so today I'm going to share with you what our solution has been. One, I would be remiss and I'll tell you my own personal story and how I come into this work is I experienced infant loss. And that was an immense amount of time that I struggled after the birth of my daughter. Because 8 years ago, loss and maternal mental health were not two things that you said at the same time. And so as I told folks that I'm definitely experiencing, if I was experiencing postpartum anxiety while pregnant, and then afterwards, not just because of the loss, I'm still the person who gave birth. I'm telling you, this is postpartum depression, but so often loss means grief, right? You go straight to grief support and that's it. That's not acknowledging me in a postpartum. I didn't get a postpartum period. I got you lost your baby, let's go over here. Support groups that I eventually went to were not inclusive of someone like me, which made me feel isolated. But even in my isolation, I knew that I could not be the only one, that there has to be someone out there that is experiencing this, and it's not just me. And so even through my own recovery, I wanted to help someone, right? What helped me personally was journaling, writing things down, but I needed motivation. And so what was one word that I could do on a daily basis to do so? And I came up with the word inspire. And okay, then what do I do with that word, right? Like, how do I learn to inspire myself on a daily? Because what I got into was a recovery state of mind. And the reason why I say recovery is because that's a day-to-day thing. Yesterday doesn't look like today, and today will certainly not look like tomorrow. So how can I do something on a daily that I feel like I'm making progress? And so I took the word inspire and made it an acronym. And so what you see here on the screen is what I've done with that. And these are the things that we need on the daily, right? The first thing we have to learn is how to involve others. The hardest thing we'll ever do is ask for help. I wanted people to be mind readers for me. Even when they asked me for help and I would say, I'm okay, I needed something, but it's very difficult to ask for help when you don't know what the help is that you need. But we first have to have the understanding of how do we involve others? How do we accept rejection when it doesn't look like what we thought the help was going to look like? How do we take what's given and then work with that? So working through what involved others looks like. And what I also want to mention is the Inspire method is journal based. So I created a journal for this. So it's about logging and writing things down. We use the word insanity, right? Doing the same things over and over, expecting a different result. This journaling inspired method actually allows you to go back and look and see, oh, this is why I'm having a bad day. I literally did the same thing I did 2 weeks ago. So it's taking a deeper look into yourself by looking at your own words, looking at your own action. And then once you understand that you're going to need help, right? Involve others. You're going to need to have somebody come in and help you with this process, but it is a process and you have to get there. We talk about nourishment and exercise. That looks different for everyone. I remember the days where I would go weeks without eating nothing more than maybe a snack or something to drink, because that's how deep in depression that I was, right? So we talk about what that looks like even on your worst day, your good day, and those in between times. Spirituality and prayer. Specifically in people of color in our community, religion is our go-to. Prayer is one of those things that sometimes we use as a cover-up. And so we address that because that's important. That's why it's included, because we know that sometimes religion and prayer can hinder us, but how can we use that to move us forward? So we have to talk through it. That's why it's included. Patience. None of us are born with patience. That is something that we learn over time. But how do you learn patience? Like, patience can make you feel uncomfortable and also make you feel like things are not moving forward. So talking through like what that looks like, writing down the things that you want to maybe have a little bit more reserved time for. The identify and initiate change. Change is inevitable, right? It's going to happen with or without us. A lot of folks will say, you need to change. This is what needs to change. But I need to identify that for myself, and then I can work on the change that needs to happen. But there's a process to that as well. There's a process to all of this, especially when we get to rest and relaxation. I know all of us on the call probably don't get enough rest. If you're hearing this presentation right now, I know you're struggling with how to rest and relax and what that looks like. It doesn't have to be you sitting on the beach. It could be the 10 or 15 minutes that you take on a daily just for yourself. But what does that look like? How to set boundaries, how to make others know and understand I need this time for myself. And then removing the blame. I don't know how many times I blamed myself for the outcome of my pregnancy. And the reality is, although folks were saying that it was not my fault, I had to realize that it was not my fault, right? That was a part of the recovery. And so that each day is a new day to start again is just that. If you don't do any other things, and it's in the word inspire, you get to the next day, you get to try all over again, and the next day, and the next day. It just gives you a reprieve. It gives you well, all I did today was start again, right? That has to be enough until you get in the way of being like, you know what, I'm gonna try a little harder. Maybe I can do this. It's you building yourself up. And then what this will also do is lead you to, this is why we start with involve others. It will actually lead you and make you more comfortable with being able to voice the help that you need. Also, one of the underlying bases for the creation of the Inspire method is that it is inclusive of loss, someone with a living birth, all the different elements of the birthing experience. One of the things that stuck out to me in my own journey on doing support is that I didn't feel included. And I wanted to create something where it didn't matter who walked through the door and what their birthing experience was. They could sit down and feel included in a group setting and get what it is that they need. In this process, I would really like to share some of our key takeaways. When I talk about the acknowledge, respect, and support method that we use, this is what I'm talking about. It's about leading with compassion in every interaction. And then also knowing that we must be inclusive of all birth stories, no matter the outcome. When we start to think that way, we become more inclusive. One of those, the first thing is acknowledgement. Like, I see you. The first thing when we interact with our clients is they need to be seen. They may have been walking around like nobody listens, all the things that's happening to them, but we acknowledge who they are right now, not who they were in the past and maybe who they will be tomorrow, but who they are right there in that moment in their need. That is so important to be seen. It's important to be seen and not feel like you're walking around and nobody acknowledges you, or you feel like you don't exist or you don't matter. So the first thing is to acknowledge a person. Respect them, because when we're coming in need of something, we already feel at our lowest of our lowest. And if you're not giving me the same respect that you would like to receive, you have to give as you want to receive, right? Respecting someone where they are and how they are. If I reach out for help, or if anyone is reaching out for help, you know that was a hard task to do. Respect them in that moment, right? I see you, I hear you, all the things. And then how can I support you? Not just what I want you to have, what is it that you need? And if it's something that you need that I cannot offer it to you, let me look for other resources to be able to do so. So you don't feel like, oh, I just wasted my time. I don't know why I came here. I don't know why I'm talking. This is not working, right? And so this is what we call individualized care. Like, you have to treat or interact with the person that is in front of you. It is not a one size fits all approach, but it's a one size fits all method. You're going to get different outcomes, but you're certainly doing and touching on the key things that will enact the change that we're all working to see. Because when we think about maternal mental health, this issue has been around for a very, very long time. Women have been suffering in silence, and yet they still suffer in silence, right? How can we push this to the forefront where we're having real conversations that move me to want to do something for myself, move me to say, you know what, I do need help. I do want to go to counseling. What can I do to help myself? Because what I know is you can fight for someone to get better, but if they're not fighting with you, it is not doing anything at all. And so it has to be a collective effort. It has to be us working together to make this all different. So it's a hand-in-hand effort. So that is the end, because again, I jumped right into the solutions and what we are working to do to move this issue forward in a better way.
Thank you, Kay. Thank you for sharing your personal story and the Inspire method. It's really quite commendable that you've been able to take such a loss and turn it into purpose. So thank you so much for sharing today. Before we move to the next section, I would love to just ask you a follow-up question. You've mentioned community, and I was wondering if you could speak to the importance of community in your work and how people in need find you and the services that the Shades of Blue Project provide.
The community is who we are. It's who I am, right? I sit in it as an executive director of the Shades of Blue Project, but I am the community simply because I know how it felt to not be able to find somebody like the Shades of Blue Project or any other organization that was talking my language, right? It's important that we embed and we go out into the community because they frame our work. They also frame the services that we offer, because we don't want to put something out there that no one is going to use. So getting community feedback and being intentional about how we care for folks. That is extremely important. That is what continues to have people walk through our door. Because they know that the care that they're going to receive from us is intentional. And again, if it's something that we cannot offer, we certainly have a network of folks who can. As far as how to get in touch with us, fortunately for me, I have built a local and national and international platform. And so the Shades of Blue Project via our website is the best way to contact us. Even for support services, we are going to start in December expanding our support services to 15 other states. So we offer the maternal mental health aspect of it, but one key component where we've been successful here locally is coupling that with the basic needs. diapers, wipes, what mom needs, what dad needs, what little sister and brother may need. What does the whole family need in order for mom to feel like, oh, you know what? I can actually focus on my mental health. Let me see how I can join a support group. So we're going to pilot this social support, meeting the social support needs with our support, online support group, merging those two things together to build out the national presence.
Wow, that sounds great. Thank you so much. Thank you, Kay, Tafadzwa, and Mirja. We will come back to you. We are off to a great start, and lucky Jane and Pandora are up now to give us a little bit of their own experience and also share their reactions to those three presentations. So I'm going to introduce you because I haven't done that yet. First up will be Jane Fisher. Jane is a clinical psychologist and Finkel Professor of Global Public Health School of Public Health and Preventive Medicine at Monash University in Australia. Jane has long-standing interests in the social determinants of women's mental health during pregnancy and after giving birth, and how these determinants can be addressed in psychologically informed health promotion, early intervention, and clinical care. Jane, I'll turn it over to you. If you could just, if you could just give us a few minutes of background about your work, that would be fabulous.
Thank you so much, and it was a real pleasure and privilege to hear the people who've spoken to us already. So I live in Melbourne, Australia, but I've had the privilege for the last more than 20 years to be working in partnership with colleagues and agencies in some of the countries of our Indo-Pacific region, and together to come to understand that every woman who has a baby has heightened needs, and if her circumstances are especially difficult because of things like poverty, food insufficiency, housing insecurity, experiencing violence, experiencing pregnancy loss, experiencing disrespectful care, all these can contribute to making her feel unhappy, at worst have the more sustained mental health problems we've been hearing about. And so I believe strongly that the approaches we've heard about, which are driven by members of the community, providing care within community, are really the way forward for the world. And one of the things that I would like to ask our colleagues about is what evidence do they feel they need in order to be able to advocate for the growth and development of their services? So to have what have started as really important movements growing out of personal experience, what do you need to persuade the donors or the health service providers that what you are doing is an essential service to women and service to the community?
That's a great question. And I'm thinking that maybe what we'll do is let me introduce Pandora so she can make a few comments about her work, and then we'll bring that question back to the others for the discussion. Okay, so next is Pandora Hartman, and she serves as the Chief Nursing and Midwifery Officer at JPIGO. She has more than 20 years of nurse midwifery experience working in the US, Caribbean, Southeast Asia, and the Middle East and Africa in varying capacities assisting women and families. Pandora, it's your turn.
Greetings to you all. I am sitting here today and there are so many thoughts running through my head. I don't even know where to start with all of this. My experience and background, I have always served, even when working in the United States of America, in under-resourced setting. So that has, from the needle exchange programs in Baltimore, in the early days, to the immigrants, undocumented immigrants of California, which it's led me to the reality, I think, that mental health is always with us. The challenges are always going to be with us when women have such trying, and challenging circumstances. So, in my work, over the years, it's very much been, yes, funding is one piece, but I think there's also the functionality piece. So what can I do as a service delivery provider, clinician, to help this woman in front of me right now? And so that is the place, I think, from which the work has always come when I'm looking at it, whether working in the humanitarian sector with women who are displaced and running. What can we give them right now? Because I think my approach perhaps is a little bit different in my work, because yes, evidence, I'm thinking about what Jane said, what evidence do we need to advocate? I kind of feel like we actually kind of have enough of some of the evidence. We know already that approximately 1 in 4, we know this. So when are we going to stop talking and actually doing some of what works? What is striking, and this is what I've always kind of tried to do. So from the functional things, such as when we're combining what we know cognitive behavioral therapy, we know support groups. So some really practical things, like when we're looking at things like the trauma tapping, which was used successfully with a lot of the sexual gender-based violence victims, and again with a lot of our PTSD and war. We know it works. So it's something simple, it's easy, it's a tool that every woman everywhere we've been able to give to them that they can do on their own without a lot of everyone. So I'm really kind of functional. And even when I think about what everyone is saying in terms of support, well, we know support groups work. We know that access, I think there's been a train of that. Where are our supports? Well, we know that we're not always able to access the support group. So I think what's already striking me this morning is some of what is done in the humanitarian sector with the cluster models. Right. So now I'm thinking, as we're having this conversation, do we need to refocus our thinking as clinicians, as providers in that? Because within the cluster models, it always said, what's water, what's logistics, what's support, what is going on in the totality of this particular woman and all of the systems that are connected. So perhaps this is a case where our under-resourced settings can actually feed high-resource settings, because we've got a larger body of knowledge around just doing what actually is working. Even when we don't have all the answers, we still have to do, I think, a lot more with implementation science. And that is the way I try to focus my work. What are the practical techniques that even grandma, auntie who's in the room with me or calling her in can help to get this woman to a better place? Because if she can't eat, right? And she's having menstrual hygiene problems, no matter what we say, we're not going to lift her out of that space of depression. And I think the acknowledging in my work as well, that guess what? Healthcare workers are people too. So that also means in terms of their own issues with loss, with pay issues, when your workers aren't getting, all of those are coming into the space. So what are the mental health issues of the service providers? What are we doing? Because I do know that training is not enough, right? Training doesn't mean anything when that woman or that man is dealing with some of their own mental health issues. Or I had an experience when I was in clinic a couple of weeks ago. I straight up didn't ask the questions. I knew I needed to do an EDP, Edinburgh scale on her, but I knew we had nothing to give her. So yes, assessment is intervention, but then when we're struggling to do something about it, what then are the resources for both the woman and the provider? I have loads to say. This conversation, I've got so many thoughts. I'll stop, I'll be quiet, but I'm excited that we're beginning these conversation and thought-provoking things.
No, I agree. It's great. And that's why you're both here as discussants, to really keep talking about the issues. And I think you bring up great points as well. And I am curious, to go back to Jane's question, if the three who did give presentations feel that they don't have adequate evidence to move forward, or if there's still things that you're looking for. Tafadzwa, I wonder if we could start with you. I think in one of our conversations, you mentioned even just having data from Zimbabwe, and what other kinds of resources or evidence would you need for your work? Jane, am I articulating your question correctly?
Absolutely. Okay. No, that's really helpful.
Great.
I think to start off, as Pandora rightfully said, that the evidence is there. What needs to be done is, can we get the ball rolling? The evidence is there. But also, yes, Sarah, when we last spoke, and I was saying I deliberately wrote that subheading as maternal mental health. But there is no maternal mental health to talk about. There's a lot of work being done on maternal health, but the exclusion of the mental aspect in it. And even if it's not included, the mental health aspect is not included in the referral pathway, what are we doing? Because you've got these community workers, and then they give the statistics to, say, the clinical setting, and give it to maybe the midwife, who only knows about midwifery, but is not really hard on bent about maternal mental health. They will just stick to the midwifery aspect. And I think Pandora alluded to that pretty well, that you may give someone pills, for instance, but it doesn't adequately address the fact that what's stressing her, the anxiety is, when I leave this hospital, the village, the community I'm going back to, tomorrow I'm expected to fetch a bucket of water. My husband probably expects to sleep with me on the night that I'm coming back, and I have stitches. And it's a lot of social elements that have a lot to deal with maternal mental health, which is why the conversation cannot just be had by women, or by pregnant women, or by midwives alone, or by gynecologists alone. It's a multifaceted approach that we need here, from the community, the partners involved, the clinicians involved, and then what happens after that. We might even need to look at empowerment, livelihood skills, so that these women do not necessarily have to rely on the partner's support, because in most cases, I speak in our setting, where you go back home and you cannot deliver yourself physically. There's always an option. And once that happens, you don't have an end-to-end means. You don't have financial support. So this woman is probably not worried about the screaming baby. They're worried about, what will I feed this child when I leave the hospital? And the clinic, if they make it there, because most of them never go to the hospital. And then we also have an issue of, I would rather fake illness and prolong my stay in a clinical setting so that I'm guaranteed 2 or 3 meals a day than to avoid going home. So it's the conversation is much larger than it actually is right now. And we need to be really brutal and candid and honest about certain elements that come to play when we talk about maternal health, let alone maternal mental health.
Thank you very much. Jane, go ahead.
Look, I think these are such vivid accounts of the kinds of experiences that women have that involve so many aspects of their lives, and of course lead to experiences of suffering. My question really is to any of the panelists, it's how do we combine professional recognition, professional service provision, with these remarkable movements that we've heard about? And I think Kay's example is so vivid, of essentially other women in the community coming together to provide practical and emotional support to their peers. And I don't think we have the answer, but I would really be interested to hear, perhaps Kay, from you in particular, do you think what you're doing actually takes the place of what might otherwise be provided by a health service? Or do you think both are needed? Because I think this is the challenge for us in responding to this experience of women. Should we be strengthening what communities do, or should we really be improving health services so they become much more empathic, much more able to respond to women's multiple needs?
Well, it's definitely going to be both. But the first step is that the value needs to be placed on the non-clinical professionals like myself, those of us that are working in the community, so we're not stopped at the door. There's always a way for collaboration to happen with community leaders and healthcare professionals within healthcare systems. I am big on going to any clinic that pops up in the area, any new hospital that is built, going and introducing myself, because here's the thing, these people who walk through your door are your patients. When they walk through our door, they're our clients. There's a level of respect there. And if they're having trouble with going into a place for care because of uncomfortability of past experiences, whatever it is, at least there's a relationship built somewhere where the two can merge and they can get the help that they need. And the fear of going and getting help or the fear of just going and getting an annual checkup is not there. It's a working relationship, right? And so both are needed. This has to be a collective effort, and collective effort is only done by collaboration. No one person or no one entity has a bigger role to play. But also what has to be done across the board in value is funding. So when Tavasa talks about funding, I know exactly what she means. For me, COVID was a reset button. If COVID had not happened, I would still probably not be on this call, just being completely honest with you. Funding, the funding that we have been able to acquire in 2020 has allowed us to do a little bit more, right? But why are we doing a little bit more with so much less? It's that. And so there's value. The value just across the board is not there. We have to start thinking outside the box, or start thinking outside of what the norm is when we think about funding and how we get there and how we move this forward. As Pandora said, this conversation around maternal mental health is something we could probably talk until the end of the week about, because the issue is that big. And until we also see that there is no maternal health without maternal mental health, we're also not making that connection, and there continues to be a gap that is not addressed. So in a nutshell, Ms. Jane, we need both. We're both equally as important. We just need to start being seen as such so we can make this all different.
Dr.
Wonderful.
Chaudhry.
Go ahead.
Actually, what Kay is saying is pulling a question to my brain. As she talked about the community involvement, can you speak to us a little bit more? Because I know WHO has some really great tools that perhaps are not as used as much as they could be, that help to involve the community level persons who doesn't have to be trained as a health worker to actually do something when we're talking about the functional piece, like the psychological first aid piece of what is available for use. An easy uptake?
Yeah, no, thanks, Pandora. And also, I think just to emphasize again and reiterate what Kay just said about, specialist care and community care. There needs to be a continuum. It needs to be strengthening of the pathway at all levels. I think we need to focus on. I think also what we need to encourage is that the specialist mental health services and the maternal and child health care programs speak to one another. And in fact, referral is not necessarily only done from the community to specialists, but also in the other direction, where the specialists would actually benefit from having people in the community, supporting, following up with women with depression and anxiety. So just want to emphasize that also. And yes, just to say that we have a suite of tools, WHO and others, but I described to you the MHGAP program, which is again, for people working in primary care and MCH services. The MHGAP also has a community toolkit. So this basically, reaches out to providers in the community platforms who may be healthcare providers, but also, community leaders. They might be, for example, faith healers, religious leaders, whoever in the community is interested and invested in, looking after people's mental health. And it takes them through a series of activities that they can do. So, from awareness raising and advocacy, and stigma reduction to, okay, like how do you detect if someone has a problem? Once you detect that they have depression or anxiety, what can you do? And
and the what of it is very much, like I said, on a spectrum. So there can be, psychosocial interventions, which can be just psychoeducation, or there can be more detailed psychological therapies or brief psychological treatments that we call them. And Thinking Healthy was one of the ones I mentioned, but the other one that you're speaking about, for example, psychological first aid, where it basically is targeted towards non-specialists working in low resource settings to be able to deliver these treatments. And there are also resources for the healthcare providers themselves. So we have, for example, the managing in times of stress, which is an online resource that was developed for healthcare providers to be able to recognize and deal with their own stress that they're going through, and using this kind of self-directed learning. So there are the resources, and I'd be happy to share links with them. So I think it's just now putting our hands in and rolling our sleeves up in a sense.
That's great. Thank you so much, Mirja. And I was thinking also maybe what we'll do is actually we'll organize amongst ourselves a lot of the different resource links, and we'll share them out once we share the recording and other things that will come after this event. So our time is going very quickly. And so we're going to move to the final Q&A with all of us together. And we have several questions that came from our audience members. And I'm going to ask them out and ask for people to give quick, succinct responses if they can, and people can jump in and respond after other ones as well. And then I might, cut people off and move on to another topic, just so we can try to get through at least 5 or 6 of these questions. So the first one, which we've touched on a little bit with COVID-19, of course, but I really wanted to ask the group a bit more. So the question is, the COVID-19 pandemic has had some devastating effects on sexual reproductive health and rights and access to services. What have any of you seen as the impact of unintended and unwanted pregnancies and lack of access to reproductive health services on women's mental health and well-being? And whoever wants to jump in first, please do. Jane, you're unmuted, so it looks like it's you.
Thank you. Look, there's no doubt that the pandemic and the restrictions that have been essential to try and prevent spread of the pandemic have had pervasive adverse effects. I think this very good question is one we're perhaps not able to answer completely yet, but we do know that access to all forms of healthcare has been more difficult. And we know that it's likely that there have been increases in unintended and unwanted pregnancies, because where families have been dealing with the stress of loss of work, perhaps both parents being confined at home, that there has been an increase in violence, including sexual violence. So there is a likelihood that this has been a problem, and women have had less capacity to access family planning and other services. So we know with COVID, there have been the immediate impacts on mental health, but we think there will be other long-term consequences, including in this area.
Pandora, go ahead.
What we're also seeing is we're seeing women again coming in way late or not coming in at all. So, from the midwives, there's loads of reports, and we're seeing people just coming into triage, not knowing they're pregnant, not caring they're pregnant. So already beginning to see issues with attachment and, babies being left later. So all of these things are already happening. With that, if we just look at the time frame, people are on lockdown, what's been happening, just looking at that, it's just more of it. So the mental health piece is just kind of more depression, detachment, kind of not caring what happens to themselves. And I will say it's very, very concerning for all of us that are involved in this line of work.
Great, thank you very much.
I would definitely add to that, as since we have 5 support groups running online, that has definitely increased. So where we've had to split our support groups from 1 into 2. So we definitely know it, because we do like a needs assessment. Yeah, there's a lot more going on because of COVID. COVID is the underlying piece to a lot of what is happening right now, and a lot of why the need increase, or the needs personally have increased as well. So definitely.
Great, thank you so much. Several questions have come in about racial injustice within health systems, and also several of you have already spoken to differences in care, respectful care in different places and for different communities. So I'm wondering, and one of those questions was, how can perinatal mental health services be developed so that they're culturally relevant? And what are some examples that you've actually seen in practice?
I think we've heard about some tonight, which are fantastic. But one example that I think is absolutely inspiring is what's called the Community Empowerment Lab in India, where an extraordinary practitioner has pioneered respectful care for newborns, which involves respectful care for women, and extraordinary narrative about the impact of kangaroo mother care on enabling women who have very few resources to grow in confidence, to feel able to care for their babies better from the beginning. And if I think this is something that's not an explicitly mental health intervention, but it's had an amazingly powerful effect on women, babies, and family lives.
Great, thank you. And I think you're right. I mean, I think if someone goes back and reviews, we've definitely had a lot of great case examples of culturally sensitive and inclusive care. So I will move on. Another question that we had is about adolescent health and pregnancy that we haven't actually talked about yet today. And I was wondering if any of you could talk a little bit about whether comprehensive sexuality care includes discussion of mental health, and how young people can access services, and what are your recommendations for making those services more youth friendly? You can just unmute and jump in.
So we work with teen moms. That's actually how I started, is working with teen moms. It's completely different. One, you have to understand where a teen mom is coming from. You have someone who's being treated as a child who has to now raise a child. The approach is different. The barriers are different, to be honest with you. So there's an age group right now that we have from 13 to 20. Because anything over that, there's a conflict, because we change as adults, right? Just mentally, how we look. And so how we approach it is certainly different. We must approach it on the level of teens, because again, if they are, for an example, if they're still in high school, they have the responsibility of high school. Most of my teen moms and dads are still in high school, have jobs, and still have to take care of this child. Two totally different. So we're addressing the mental health component and aspects that they may be dealing with, and the maternal piece of now having to take on these adult responsibilities. Typically here, where I'm from, there's a lot of education within the schools as far as educating around early pregnancy, simply because they have built like a school inside of a school. I'm not okay with that, because that separates, but nevertheless, they give support, but they don't give this type of support. It's really just like something that they insert in to say that they are addressing the issue, but not oftentimes looking for ways to bring in other solutions, like again, engaging with a community organizer, meeting those basic needs. So teen parents still have the same needs as older adults, right? They still need those basic needs met, but they also need that emotional support. So it's coupled with both. It's the mental health and the maternal mental health. Honestly, you can't do one without the other. I think that's a piece that is often missing when we are talking about how we support our teens. Mental health coupled with the maternal side of it, because they are up against too many other things at the same time as young adults.
Great, thank you. We've also gotten several questions that don't really go perfectly together, but I'm going to try to put them together. to respect our time, but they're really about inclusivity. So we've talked about, race already to some extent, but also then talking about members of the LGBTQI plus community, particularly transgender and non-binary parents, including in these services, including people who experience loss, stillbirth, and miscarriage. And we've spoken to this some, but how we can include these people as well in our services during the perinatal period. Also, which we've also touched on a little bit, but if people want to speak to fathers or partners, and caregivers, how other people can be included. Those were 3 separate questions that came into us, and just really to kind of touch on the inclusivity piece that I know several of you have spoken to a bit, but to kind of deepen that conversation just a bit. So we've got LGBTQI plus community, fathers, and those who experience loss. Who wants to jump in?
I'd be pleased to tell you what we've done in Vietnam with the inclusion of men. I think it's absolutely essential that any of our efforts to promote and prevent mental health problems are inclusive of co-parents, including babies' fathers. And often what I think can do most effectively is take an educational approach, because while all of us feel incompetent and underskilled for care of a baby, I think this is amplified for men. I think when they get anxious, there's more of a risk of them being avoidant. And what we found is if you actually teach a man how to bath the baby, how to wrap and soothe the baby, how to share the housework with very practical demonstrations, this makes an enormous difference. This very practical, inclusive educational approach, which is coupled with empathy and psychological support. And I've heard that a lot tonight, that respect, empathy, inclusion, consciousness of language are really essential skills for this. But we have found that there have been very big changes that are now sustained. We've followed them up 2 years after the babies are born, and the mental health benefits for women are there. The benefits for child growth, health and development are there, and there's much less conflict between the parents. So I think there are promising practices that provide us with an example.
Great, thank you. Nirja, go ahead.
Thanks. No, just to also highlight what Jane has said and continue on that same theme. Speaking about fathers and their mental health, I think this needs to be also part of these integrated within wider mental health awareness activities, in a sense, so that the fathers recognize that if it's depression or anxiety or what their mental health needs might be and where help is available. I think a great setting in the community for this kind of intervention, if you call it that, is the workplace. So, increasing mental health awareness in the workplace, and so kind of they're more aware of this, tackling the stigma associated with help seeking, and also somehow explaining the benefits that seeking help would have, not only for the father himself, but also for the family, for the spouse, for the child. I think that would be important. And I think one easy way of doing this is to, if the woman is willing, to include them in sessions, where the woman is receiving mental health care or services.
Thank you. Pandora, go ahead.
The conversation is, when I'm thinking about the issue of loss as well, we actually have more work to do in this maternal mental health space surrounding that, actually kind of at the policy level. Just last week, I heard a heartbreaking story of a woman who's now diagnosed and she's having the depressive and she's okay and she wants help. But in terms of the leave policy, right? That was for that particular job around her now having the space to take that 3 months off, that was their right. It then became an issue of us having to advocate, to fight, to get her time off. So, there's that larger lack of acknowledgement of this as a part of the process that I think as advocates in this space, we cannot deny to look at what's happening in terms of the insurance and the payment. It's also when we're looking at loss and stabilizing the mental health, if I put on my service provider hat, is the awareness that, okay, well, the baby's birthday would have been X time. So maybe I need to bring her in for a visit. Maybe we need all of these other sorts of things. So the policy piece, huge to work on, and then like the functionality so that providers remember that this spirit came here for a reason, and that there was an impact of that spirit upon the entirety of the family. And I think as much as we embrace fathers, I think this is another space where we also have to be really culturally aware and culturally sensitive as to norms, so that when we're looking at this space, we're not just putting the Western value and viewpoint about how it should look like. This has happened, I think, a lot in maternity care spaces is, it's come with a very other lens. So they should be doing kangaroo. They should be there, but maybe that's not the way it needs to be in that setting. So I just kind of, as much as we embrace, to also put in a word of caution as we look at some of these other issues surrounding the mental health space. And for me, it's also the acknowledgement that we're talking about maternal mental health, but it's the same with adolescents. That's too late. We need to accept this as a part of women's care, from menarche onwards, accepting the possibility that depressive episodes would come in and possibly come in, 1 out of 4, and normalizing our approach to getting in early, warning signs, symptoms at every potential visit, as much as we integrate family planning or hypertensive screening, to look at how we integrate this into the broad spaces of all health.
Thank you. Tafadzwa.
Well, it seems Pandora was in my mind there, because she literally just took out all the words that I wanted to say. Well, first of all, I was going to start off by saying all our decisions need to be policy informed, because we may sit down and say this is what we want to do, but where are the governments? They should be more aware of what mental illness, the effect it has on the general and overall GDP of a country, of a continent. And then we look at paternity, like you take your maternity leave from work. I strongly advocate for paternity leave as well. But like Pandora was saying, we've got cross-cultural issues to consider. Jane suggested that you can bring in the man when the woman is receiving therapy or counseling or going through her sessions. The African man will feel a bruised ego if you just put them in at par with the woman. So we also need to look at what works in one setting may not work in another setting. It may work, but there also has to be another step added in. We will get to the part where the man and woman receive counseling at the same, or therapy, or go through sessions at the same level, but there has to be something included prior to that. So we may have to alter the solutions here and there just to fit the cross-cultural elements of our interventions.
Thank you.
I'd also like to add to that, which will pretty much touch on the loss in the LGBTQIA, I always want to say it correctly, is that we have to start looking, it's one thing I always say about the birthing experience, and everybody's birthing experience doesn't look the same. What is traditionally what we've seen as mother, father is not what it is today. And so we have to step into the millennium, to be honest with you. And we have to do that across the board. We don't get to pick and choose when we don't, because we don't ever know who's going to walk through the door. And so we have to remove our own biases, right? That's a piece. Inclusivity, again, includes all, and not separating, And so again, if all the birth experiences matter, then we're talking about all. Now, when we think about the fathers, I just feel like we've gotten to a point where we haven't even got a concrete solution for women yet. And so if we then bring in partners in a way that is not productive to the person who's giving birth, then are we helping or are we causing harm? So it's that not one size fits all approach. Finding many different solutions to be able to apply them to the person that is sitting in front of you. That's how this whole thing is going to work. We have to be prepared for anything in all things, right? Even if we never use them, we're at least educated and prepared for them. And then again, making those suggestions so that we are giving and delivering care that seems personalized. Like, oh, you're not talking about all of us, you're talking about me. So that's my input on that.
Thank you. I really appreciate that. I still have so many questions, but we have 5 minutes left. So I'm just going to ask this one actually that made it so far down on my list, but is really, really important. And people have touched on it a little bit, but I think we could spend, if every person wants to just speak like 30 seconds about healthcare providers. What support do you recommend or successes you've seen in supporting those who are providing the care? And that's how we'll kind of close out the session. Go ahead, Tafadzwa.
I think this was mentioned before that healthcare workers are humans too. I strongly am for the idea of a pre-briefing session before work and a debriefing session after work, though cautiously treading on the fact that not all workers get along and not all setups for work counselors or office counselors are the most ideal. So to have group activities where you include, say for instance, the INSPIRE method, but in the workplace, and have that, the exercise element, the dancing, the laughing, an activity before work and an activity after work, and then just open up a platform. What happens with humans is we will gel eventually, and you will find your person who you can confide in, and then pre-brief and debrief, and then we don't have that work-home burden carryover or home-work burden carryover.
Thank you, Neerja. Go ahead.
Just to add to what Tafadzwa has said, I think what's extremely important is that healthcare workers, as a part of their training, are trained in how to recognize symptoms of stress in themselves and where they can get help for this and what they can themselves do to reduce that stress. So even before, they experience anxiety or depression. The other method is to have peer support groups, which have been effective in supporting non-specialist healthcare providers who are providing mental health care. And there are examples of this in many parts of the world. And really the third thing is supportive supervision, which is extremely important. So we train healthcare providers to deliver mental health care, but they do need ongoing supervision and support for this. Thank you.
Thank you. Jane?
I think building on what Neerja said, many people say mental health care is beyond me, I don't understand it, I can't do it. But in fact, everybody can do it. And everybody who treats a patient with respect and kindness and empathy and a willingness to hear what the experience is providing supportive mental health care. But I think the points that Neerja's made is very important, that people are more likely to provide that care if they feel respected and valued in their workplace, if they feel their work is noted and acknowledged. So it takes supportive supervision, but respectful leadership to enable providers to care for patients in these ways.
Thank you. Pandora or Kay, do you have any final thoughts?
I would just say to remember that we are not heroines nor angels. because that sets up a realistic expectation of what that given health worker can do in that day in their environment with what's in front of them. And once we work on that, we'll have a more reality-based approach to improve not just maternal mental health, but all elements of healthcare.
I would wrap it up by saying that
Yes.
this is a collective effort. We all play a part. It is about doing your part the best of your ability, and then also building upon what your ability is. So it's a collective effort. What you've seen today is a collective effort. What we can do within our system also has to be the same.
Perfect. Great way to wrap up. And I absolutely agree. Today has definitely been a collective effort. I have learned so much, and I'm sure our viewers have as well. As I mentioned in the beginning, the event recording will be available later today. We will also publish a summary of the event on our blog, New Security Beat, on the .mom column. Thank you again for all of you, for all the hard work you put in before this event, and for showing up today and giving such incredible, truthful responses. This was really an incredible experience for me. And so I really thank you, and I hope we can all stay in touch. And for everyone online, thank you again for sending in your questions. Please do reach out to us. We would love to collaborate. And everyone have a great rest of your day or your evening. Jane, get to sleep in Australia. And I really hope to stay connected with everyone. Thank you very much.